Hi, and welcome to Life, Love, Insight, Fertility Experiences. Today we're going to hear all about how an embryo is created in the lab, which is something so many people wonder about. And I am here with Dr. Carol Curchoe. And welcome back. I am so glad that you were able to, or we're able to kind of have this piece of the conversation. We're still on Zoom, we're still kind of staying quarantined when we can, so who would think it would have been this long? But you're
Well,
back.
it's wonderful to be back. Thank you for having me.
Oh, thank you. So, people reached out to me after our first conversation, so interested in what really goes on in the lab. So, it's exciting to be able to talk about what you do exactly after the retrieval comes in of an egg or sperm, and if the retrieval is coming in from a couple or from a donor in some form. So I'm not sure where to begin, but we kind of talked about the ABCs of creating an embryo. So
Yeah, I think it's such a good point, and it's such an important question, and it's something that I feel strongly as an embryologist we need to be more transparent with our intended parents or our parents about, because they do so much work to get up to that point of the
I
egg retrieval.
do.
All the stims, the medications, the this, the that, and it's so much. And then they go in for the procedure, and their precious tissues, their gametes, disappear into the black box of the
Right?
lab.
And they have so
That
much
could be
anxiety.
provoke so much anxiety, yes. And then they're waiting for the updates as the cycle progresses. It can be very painful for people, because
I
you
have the
tend to
chills. It
start
is
off.
painful. I have the chills as you say that because from
Mhm.
my end, when I'm talking to people, it is so anxiety. And do we make it to the third day? Do we make it for the fifth day? So,
Yeah. So maybe if we can shed a little light on some of what happens behind closed doors, it
yes.
can be helpful to manage the anxiety during that time.
Yes.
So let's just start right at the retrieval.
Excellent.
Usually, the patient or the egg donor will come into the surgical room, and they might briefly see the embryologist, who will be taking the tubes of follicular fluid into the lab. Usually, the tube gets passed through a small window. And before the pandemic, in a lot of places that I've worked and a lot of people who I've talked to, we would go in and talk face to face with the person. We would confirm their plan for their cycle, and how exactly they want their embryos made, whether they're doing PGT testing, if there's more than one sperm source. Sometimes you can use a partner and a donor in the same cycle, and you just confirm in general the embryology plan with the patient. But
So
now less of that
fascinating.
is happening.
Yeah, that's fascinating. Honestly, Carol, that would happen. That you would have a choice of what kind of sperm do you want to mix the sperm together, and how you want to proceed with that, and whether or not to do the testing, because the
Yeah.
testing takes place in the lab, and people have mixed kind of feelings about that depending on the position you go to.
Yes, absolutely. And then it can be further complicated by pricing plans and packages, how many embryos to test, and it's can be very stressful for the patient. So, but in any case, what happens when the patient goes under the anesthesia is the so they'll put the patient to sleep, and they'll put the legs up in the stirrups, and the nurses and medical technicians are all working hard to keep the patient's skin draped with surgical drapes and the patient covered every time the body is moved. So one of the utmost, important things for us all around the patient is to preserve their dignity after they get put under anesthesia, and to really respect the human body. And we dim the lights. We don't like a lot of bright lights shining on bare skin, and we will drape every basically inch of exposed skin with surgical drapes and sterile towels. And we all work very carefully to make sure that everyone is sort of at the flank or the head of the patient except for who needs to be directly in front of the um, where the ultrasound guided transvaginal oocyte aspiration will happen. So most physicians will use Wanda. And if you've gone through a cycle before, you know exactly who Wanda is. Wanda is the ultrasound probe. And the ultrasound probe, they do insert vaginally. And then there's a guide on the front of the probe where the needle actually goes through. So it will be directly through the muscular wall of the vagina into the follicle. And a technique that I've seen work really well is when the physician makes one puncture through the wall of the vagina, but they can reach multiple follicles through that site. So sometimes, if a retrieval is very difficult, one of the things that can be difficult is if the ovary inside the body is behind the uterus, or uh, if the walls of the abdomen are very, resistant to the ultrasound if they're using a abdominal ultrasound. Um, so it's on our end, the embryologist end, what I tend to see is either tubes that are very clear with follicular fluid, very little blood, or sometimes they have much more blood in the tubes of fluid. And this all goes in to help with the recovery of the patient afterwards. I can imagine that less puncture sites means a quicker recovery
Yeah.
ultimately. But what happens is there's this long needle and they insert it into each follicle guided by the ultrasound, and they suck all the follicular fluid out, and that follicular fluid will contain an egg. And what we tend to think is that if you have any follicles over 14 millimeters, those are the ones that are most likely to contain a mature egg.
Okay. And what
So
happens if they're under?
usually, so there's three different stages of maturity of eggs. Very immature, which is called a GV, moderately immature, which is called an M1, and then the most mature type, which is the type we can do the injection on, the ICSI injection on, or the um, conventional fertilization. But most people use ICSI nowadays, and we can talk a little bit about why that is. But the most mature eggs are the only ones that can be fertilized.
Okay.
So we so so this is kind of the first step where patients tend to lose eggs. The
I
doctors
think it's
might tell them
important.
that you
Yes.
have 20 follicles, but then you only have 10 mature eggs because there was a certain number that were over 14 millimeters.
Yes. And I think if you get 10 out of 20, that's really a wonderful statistic.
Yeah, and even more than that, I would tend to say I think about 80% usually of the follicles contain a mature egg.
That's really interesting because I haven't heard that before. I usually hear that much less,
Oh,
especially as women get a little bit older. So I'm really happy to hear that number. Okay, I'm sorry to interrupt you though. Let me let you.
okay. Yeah. And so then the eggs are surrounded by cells. During conventional IVF, that's where you simply combine the eggs and the sperm in a dish. You don't get to grade the eggs on their quality or look at the maturity because they stay within those cells.
Okay.
So this is one of the reasons why I don't like to do conventional IVF. I prefer to do ICSI. ICSI is intracytoplasmic sperm injection, where we choose the sperm cell and we inject it directly into the egg. ICSI was developed in the 90s basically to overcome a lot of problems with male infertility, but it can actually overcome a whole lot of different problems. One of the biggest nightmares that we used to have would be when we would go in the next day after a conventional IVF and see a failed fertilization. Is the sperm could not get through the cells surrounding the egg or penetrate the oocyte when it got through those cells, or for whatever reason you know the sperm did get to the egg, but the process of fertilization just didn't happen. When we use ICSI, we see that much less.
Yeah, it makes sense now because you're choosing probably the strongest sperm or the best graded sperm to put in to the egg.
We use a very high powered microscope to look at the sperm, and it can be hard because they're swimming and moving, and you want the ones that are going the fastest. So they're actually, even with a very high-powered microscope, they're very difficult to see. You can mostly see the head and the mid piece, but and you're trying to see the tail as best you can, but the
How do you
tails are
catch them?
moving back and forth.
How do you catch the fastest ones?
So we actually put them into a very thick, viscous solution that slows them down. And
Okay.
so that slows all of them down equally, but without that solution, we would never be able to catch them. And they are really, really quick.
Uh-huh.
And
Keeps you on your toes for sure.
yes, yes. And especially, when we do our process of washing the sperm, we are actually taking out, there's in a normal ejaculate, there are a lot of sperm that are not motile. There are a lot of sperm that are very abnormal. In any typical ejaculate, that's the case. So we always do a process of purification first. So the sample that we use for ICSI will actually contain the most highly purified, most motile sperm of the whole sample.
So
So
after you catch them, then you put them into the solution.
so we put them into the solution first, and then we catch them. We use a needle basically to slash the tail. That immobilizes the sperm, and then we pick it up by the tail and inject it into the egg.
Wow. Okay. Sounds exciting.
Technically it's microsurgery because it's doing surgery on a single cell.
Yeah, it's
Uh,
amazing like how you get that and how how you have it put into the egg, how you inseminate the egg. It really is.
and then
Exciting
just because
too.
we put a sperm and an egg together doesn't necessarily mean that it's going to fertilize. So when you put the sperm and the egg together, that's called insemination. But the next day, and the day of the egg retrieval, by the way, is day 0. The next day, when we look for fertilization, that is day 1 of embryo development. And when we look for fertilization, we're looking for the 2 different signs of fertilization. We want to see 2 nuclei inside of the egg cell, one from the sperm and one from the egg. The nuclei are what contain all the chromosomes. So you want half to come from the mother or the egg and half to come from the father or the sperm. And it's kind of an exciting moment for embryologists because this is the last time that your embryo will have 2 separate genomes inside the cell. The very next step after that is those genomes come together in one nucleus, and your embryo has its whole own genome.
Wow. The way you describe it, it's such an exciting thing to be part of.
It is so exciting. And it's even more exciting when those fertilized eggs go on to start dividing.
Yes. Yes, I agree.
So on the first day, we look for the signs of fertilization, and then we usually let the embryos just sit for the second day. We don't disturb them. We go back and check on them the third day. And on the third day, we want to see them be between 4 and 8 cells. So one cell should turn into 2 cells, and then each of those cells will divide. So 2 should go to 4, and 4 should go to 8 by
Right.
day.
That's really
And
such an important day for people.
it
That's,
is.
everybody
And
wants that call that day, and they don't really sleep.
yes, and at that day when you know how many are dividing and you know how many cells they have and what the quality looks like, you can kind of have an idea of how many are going to roughly make it to the blastocyst stage.
Right.
So
Which is which day? Day 5.
day 5,
Yes.
yeah. And so you really want the embryos to be 6 cells, or more 8 cells on day 3. Um, I have seen 4-cell embryos make blastocysts, and of course it does depend on if the ICSI was done, at the end of the day, and then the day 3 check was done early in the day on day 3. You will see 4-cell embryos, but on day 3, what happens is there's something called the embryonic genome activation. So the embryo up until day 3 has been nurtured by factors that were present inside the egg. On day 3, the embryo's own genome has to start working.
Wow.
And that's where a lot of the drop off happens between day 3 and the blastocyst stage.
Right. So if you wanted to, if you don't mind explaining the blastocyst stage to people, that might be very helpful.
Absolutely. So we check for blastocyst development on days 5, 6, and 7, typically. And what a blastocyst is the embryos that have cells that you can count, those are called cleavage stage embryos. And that means that each cell is dividing into exact copies of it. In the animal world, we can actually take embryos at that stage and split them and create twins.
Wow.
At that stage, each cell is capable of becoming another embryo. But what happens at the blastocyst stage is the embryo actually starts differentiating into two different tissue types. We have now the layer that is going to become the placenta, which is called the trophectoderm, and a mass of cells inside that, which is a tight ball, and that's the inner cell mass. And the inner cell mass is what will become the fetal tissues.
And that's really day 5.
It usually starts about day 5.
Yeah.
And so the majority of embryos will grow to the blastocyst stage by day 6. Some slower growing ones will go by day 7. And day 7 is really the last day we can keep embryos, human embryos, in culture in the lab. And so on things,
I was going to say, so many people go day 6 to have the insemination.
To have the transfer.
I mean, I have the transfer. I apologize. I have the transfer.
Okay. Yeah. Yes, to have a fresh embryo transfer. But nowadays, I think most practices are turning to what's called a freeze-all strategy. So typically what we're doing nowadays is letting the body rest after that intense stim cycle and preparing the endometrium in a separate cycle for an FET, a frozen embryo transfer. So anybody who has taken stimulation medications or is going to will know that the hormones you're getting pumped full of can really do a lot to the body. So nowadays the preference seems to be, and really increased pregnancy rates come from this, to freeze all the embryos on day 5, 6, and 7 and then transfer them at a later time in a separate cycle where the endometrium of the uterus has been prepared separately. And now we're even starting to see that, the typical way that people have been thinking about the endometrium is you prepare it for a set amount of days with progesterone, and everybody is going to have a uterus capable of receiving an implantation with a certain course of progesterone. And what we see is with stimulation cycles, it really needs to be tailored to people's personal follicle development. Nobody would ever do a stimulation cycle without monitoring the follicles and adjusting the meds as your cycle goes on and stopping it at a certain day. And we're starting to consider that progesterone priming the same way. So there's a new test that can be done called the endometrial receptivity assay. And that is you'll do kind of like a mock cycle where they prepare your endometrium and they'll take a tiny painless biopsy of it on day 5 to see if it is receptive at that point to take an embryo or if it needs a few extra days of progesterone priming. So that's one of those kind of like advanced techniques that if especially for women that have had a failed transfer with a genetically normal embryo and there seemed to be no reason for that embryo to not implant, they might want to look into this ERA testing to see what the genetic and the cellular response to the progesterone is on day 5.
So the CRA is that, could you explain that a little bit? You're giving us such a wealth of information today.
Yeah. So it's called ERA testing, endometrial receptivity assay. And the ERA testing will, they go in with a small pill and they take a little biopsy, very painless, of the endometrium. And what they're looking for is a molecular and genetic signal from those cells that they could be receptive to having an embryo implant in them. So the process of implantation is really a lot of crosstalk between the embryo and the endometrium. So
It's like it.
a lot of infertility is you're making perfect embryos, but the embryo is not implanting the right way, or
When
it's
that happens, yeah, it's so hard for the intended parent because
yes,
the egg is there, the embryo is there, the sperm's there, and it's just
yes, right. You have plenty of eggs in your ovary. You're not suffering from diminished ovarian reserve. You're making beautiful embryos, and then for whatever reason, the endometrium and the embryo are just not communicating well.
right.
So that's sort of a cutting edge, aspect of embryology right now that is being, researched, debated in the field, and there seems to be a lot of good results. And I'm sure we're going to see a lot of movement on that in terms of protocols coming in the next few years.
I hope
Because
so. I hope so because it would be wonderful to be able to figure out what it was that was
yes,
stopping this, and it would be a gift.
absolutely. And
Yeah.
in general, in the field of IVF and embryology, we've had a couple of these moments where we've seen a huge, what they call like a step change. So
Mhm.
we were at one level when we were transferring day 3 embryos, but we know that a lot of day 3 embryos look beautiful on day 3, but they're in fact arrested. They don't go on to make a blastocyst. So before we used to not, we didn't culture to day 5, we cultured to day 3. And now we changed, we cultured to day 5 now, and we can see about 50% in a lot of cases of embryos stop developing at day 3. And before, those all would have been transfers, individual transfers. And you would have had those day 3 embryos transferred back and not known why 50% of your transfers didn't work out. But now we know it. So that was one of the innovations that really allowed a giant leap in success rates in the field.
Yeah, and I've kind of seen, the from my perspective, the change of the 3 day
Yes.
to the 5 day. It, it's shifted, and you do see better outcomes. But at what point do you do the testing, the PGA testing?
So that is done on days 5, 6, and 7. The biopsies are done on day 5, 6, and 7. And what the biopsy does is it takes a few cells from the trophectoderm layer,
Does
and
that
it looks
hurt
at
it at all? That's always a question that people have.
what is.
Does it hurt the
Oh, does it hurt the embryos?
is there any
You know,
negative
so
impact?
each embryo is kind of as individual as a child itself eventually will be. And in general, we think that there's very little impact, but it is true some embryos just do not like to be biopsied. And then we don't find that out really until we go to thaw that embryo. It can be a long time before we find out whether that embryo will survive the biopsy and the freezing and the thawing procedure.
Right.
So a couple of other of the innovations that are happening in the field right now is currently we use a laser to clip off 5 or 10 cells from the trophectoderm layer, which is the layer that will go on to become the placenta. And what researchers and scientists are looking at now is, are there non-invasive ways that we can study the DNA of embryos and understand whether the chromosomes are normal number or not, but without hurting the embryo? So it's called non-invasive biopsy. And we're looking, basically, the embryos are growing in a culture media, which is like a lot of sugars and salts and, the food for the embryo, the energy for the embryo to grow in. So we're looking at that spent culture media now, looking and seeing, are there cells that have been shed from the embryo? Can we get DNA from them? Are the embryos shedding those cells because they were abnormal and they were excluding them? Or can we look at those cells and see if we can really gain good information about the quality of the embryo from that DNA. And so it's really cutting edge science actually that's happening right now as we speak, and it's just being published on.
It sounds so
But
exciting, and so important to do. A lot of people want to do the testing, and some of the doctors don't believe in the testing. So it's always a question that people kind of struggle with a little bit, and it's expensive. So there's so many different factors that go along with that. But I think,
absolutely,
no, go ahead, I'm
it
sorry.
can be very lab specific. I think that's maybe one of the problems because even as scientists in the field, we have had a hard time of saying, is this effective for everybody? And and I really do think that that lab to lab variation um, is really preventing us from having a definitive answer for patients.
Yeah, you mentioned something about the differences in the labs last time we talked, and we actually were talking about the application that you founded, the ART Compass, and how it really helps people to bring things along from place to place, giving the history and empowering the intended parent with the knowledge as well as the team of doctors or nurses or embryologists working with them. So that variation, I think, is something that people don't necessarily have at the forefront of their mind, but the lab is really where it happens. In the womb and in the lab, and it they just go hand in hand from my perspective.
Absolutely, absolutely. And the lab is essentially the substitute for a human organ.
Yes, it really
So
is.
we, that's one of the things that we really, part of a huge part of our jobs is to make sure that the environment inside the lab is essentially the exact same as a human fallopian tube.
It's amazing.
So
It really is. So
we
I'm
have
so glad
to
that you're here to talk about
monitor like the humidity and the temperature
it.
and the pH and all of those things so that it's just like it would be inside your body.
Wow, that's really interesting. Before we started, we chatted for a minute, and we don't have a lot of time left, but we chatted for a couple of minutes about when people use donor eggs and donor sperm, and how that is because it's almost it's a totally different process in many ways, right? I was going to for people who are doing this. I'm bumpering. I apologize, but for people who are trying to conceive and now it's not their egg, so they don't have to go through having their eggs taken, but yet the egg still goes to you, and the sperm you're getting maybe from the father of the intended parents, and maybe not, maybe from somebody else, or there are opportunities maybe when you're using sperms from two different donors.
Absolutely.
Those are all
Yeah.
fascinating things. Does it change the process in the lab when that
So
happens?
it does in terms of the tracking of each cell and the um, like labeling the dishes and that the embryos are growing in and all of the tubes of media that are used because we really cannot you cannot mix anything up in the lab. And it's very important when you're working with anonymous tissues to maintain that anonymity in the case of anonymous egg donors. And in the case of sperm donors, and you're creating these embryos, there's a lot of FDA regulations that we need to be aware of as embryologists, and who can receive those tissues, how the tissues were tested, because then it becomes a like if you think about it, it becomes sort of like if somebody's donating a kidney, right? It's that same level of you are having a tissue that was created with somebody else's cells implanted into your body. So the FDA oversees that and regulates that whole process. It's very intense because we have to make sure that the donors are all tested appropriately, all for communicable diseases, HIV, you know, hepatitis, and everything for that tissue donation to occur. And those
And
embryos,
I'm also thinking in the case of a couple, maybe a gay couple, where they both want to donate sperm. How do you do that? Do you have any understanding of which sperm is being used, or is it you just taking the fastest one?
no, so we would keep them separate. under all circumstances. So we have to know exactly which, we wouldn't mix them together, in other words. So what we would do is we would make 2 sets of everything, and one would only be for one sperm source and one would be for the other sperm source. And those embryos would be labeled differently. They would be frozen according to the source of the sperm.
Right.
Yeah.
Okay, and ultimately, probably the sperm that would be the fastest, and the one where the embryo formed would be the one that would be implanted, and the others might be frozen, as long as they were good.
Right. That a lot of times that is the case where the patients would like you to pick the best embryo. And so they will leave it up to sort of the embryologist's discretion to choose the best embryo.
Right, right. My husband just walked by. Did you see
I
that?
know.
Could you stay in the room, please? Thank you. Oh my goodness. So anyway, well, I think that this was great information. I really do. And I appreciate it so much. I'll tell you a funny story. I don't know if people are interested or not, but I was having physical therapy at home. And so when the virus first started, I would make my husband take off his clothes when he came home. I know. And I would say, don't, you have to change your clothes when you come home. So I was on Zoom doing physical therapy, and my husband walks in with nothing on, and the screen froze. My poor physical therapist. So anyway, the pleasures of doing this at home. But
I know.
this has been a wealth of information, so I really appreciate it. I'm not sure if there's anything else that you want to add before we end.
You know, I don't think so. I think we pretty much covered the basics of embryo development over the 7 days that the embryos will be under, my care in the lab. And I always like to tell patients, like, I am your first babysitter. I really am.
I love
Like,
that.
I am a part of your family. My favorite part of being an embryologist, or one of my favorite parts of being an embryologist, is when I freeze the embryos, because I feel like I'm putting the babies to bed until their parents can come back and pick them up again. And that really is what it feels like for me. Like, I am putting all of your babies to sleep right now in the freezer, in the deep freeze, And
Love that. I just love that. I think that's so fabulous. Years ago, when I first started, that is the most beautiful analogy. I'm the babysitter putting to sleep. Years ago, when I first started working in fertility, I was working with one couple, and he, for some reason, was taking the embryos to the doctor's office. He picked them up from the lab and was taking them. I'm not sure why he was doing the transport. So he went into Starbucks, and he took a picture of himself with like this cooler, and he sent it to his wife, and he said, "I'm taking the kids to Starbucks."
That's so funny.
I haven't thought of that story in a while.
Well, Lori, World Embryologist Day is coming up. It's coming up on the I believe it's the 24th. It's the birthday of the first IVF baby ever born.
Mm-hmm.
And it's really a day to honor, embryologists patients, that's maybe one of the silver linings of the pandemic, is that I've gotten to do a lot more of these Zoom calls and live events where I can really get to meet, people and help to shed some light on the profession of embryology. And people a lot of times would never get to talk to their embryologist otherwise, or maybe only see them very briefly for those 5 minutes before the retrieval. And so it really is a pleasure. It's the honor and the privilege of my life, really, to be able to create families for people and have this role in the world.
Well, your love for it just exudes when you talk about it. So I adore it, and I'm so thrilled that you came on again to explain this. So thank you so much. If somebody wants to get a hold of you, is there a way that they can contact you?
We're very active on social media. The best way is to really follow. You mentioned our application that we developed. So we developed an application called ART Compass, and our Instagram handle is Art Compass IVF. And Our app really helps patients to stay better connected to their doctor and their IVF practice. It literally puts the clinic administrators, scientists, physicians, and patients on the same page inside the app. You can see images of your embryos, you can see their genetic testing status, and in the case of donor recipients, it can probably help you feel much more connected to what's happening in your cycle, because you might never step a foot in the clinic until it's time for your gestational carrier to have their transfer, for example. So yeah, we're really active on Instagram. I'm willing to take questions. I'm an expert on the Fertility Answers, the Meta Answers Fertility Answers platform, and so I'm reachable there as well. Patients can directly just reach out on social media.
I
We're
think
there
that's
all the
great, and your posts on ART Compass are fabulous because they give you so much information. So I always appreciate reading them.
Oh, thank
So,
you so much. I have a wonderful team that helps me. We strategize each week to try to figure out what our followers might want to hear about that week. And we try to keep things timely, relevant, educational, inspirational. And so, it's my team, especially thank you to Pooja on my team for help with the Instagram posts, the content,
oh,
and the quality.
thank you so much. So, if anybody has any questions, please reach out to Dr. Carol Curchoe at ART Compass, and I know that she's going to get back to you. And if I can help you in any way, please reach out to me at lauriemetz.net. Thank you.